Welcome back again, everyone. I'm very delighted that there are so many GPs who've been able to attend this meeting, and I just thought I'd mention that we have got a BMJ masterclass coming up on the 1st of December. Although the title, to my mind, is slightly off-putting, Improving Quality in Your Practice, there's a marvellous session on it which says Improving Care Without Working Harder, which I thought would be attractive to people, and how to make change and measure improvement. I think it's going to be an excellent session, 1st of December, and if you register or if you tell others at the meeting to register here, there will be a discount for those attending this meeting for this subsequent meeting, so I do hope you'll take up that offer. Now, who among you, and indeed who among us, could sustain a weekly column based entirely on their own opinion? Well, Des Spence is such a man, and I think we all have to bow to him in view of that. He's a GP full-time working in the inner city of Glasgow, and has written now for the BMJ a regular weekly column since 2006-ish, which is a triumphant achievement by anyone's books. He says he writes in the hope to amuse and offend in equal measure, and he certainly does that. I asked him which column had most offended people, and he immediately leapt upon the one about anaesthetists, which suggested that they might actually do some work while the operation was going on, such as taking calls from NHS Direct, or actually contributing in those long hours when all they're doing is sitting twiddling their thumbs. He also, however, did a column on chronic kidney disease, which produced an enormous response. He was making the point that although this may be a marker for ischemic heart disease, there was no evidence base for intervention in people who had abnormal results on their kidney function. And this was something which was being promoted as something that GPs should be doing. So he's a very evidence-based commentator, and we're very proud to have him as a regular columnist on the BMJ. He's told me he's completely ignoring the remit he was given, so I'm handing over to Des Spence.
Hi there. Yeah, the initial remit was looking at the implementation of evidence into practice, and I was sitting down trying to think about that, and I thought, well, that's so straightforward. It hardly needs a speaker to talk about it. But so I thought I'd come up with a sort of suitable title for this. It's gobbledygook, because sometimes much of the evidence base sometimes is gobbledygook, and if we want to talk about implementing changes in practice, it's actually very straightforward. And in the UK we've had something called the Quality and Outcome Framework, which are people familiar with. It's an incentive scheme to bring about 1,000 quality points in primary care to improve the quality of evidence delivery in the UK. It's been running for 6 or 7 years now, and in many ways is the biggest sort of public health experiment, biggest trial, if you will, of evidence-based medicine. Regrettably, its impact upon outcome has been very, very weak. So my thinking when it comes to evidence-based medicine and how to implement it, it comes into there's two drivers. Okay, force. If you want people to change, then you merely threaten them, or you pay them, which is what they did with us within the QOF. So there's not, in my view, there isn't very much more to say about implementing evidence. Implementing evidence can be very straightforward as long as you use the right levers. You may disagree, but that's anyway. So then I thought, well, what can I do that would be interesting? And clearly, the people here today come from a background of evidence. Clearly you have an understanding of evidence-based medicine and clinical care. And I thought it was important that we talk a lot about improving quality and the quality of evidence, but do we ever look at evidence-based medicine? Do we ever look at the problems of evidence-based medicine? And for me, that evidence-based medicine has delivered a sense of absolutism that isn't warranted sometimes, and that we need to sort of question some of the premises that we use within evidence-based medicine. Does that make sense? So I do a column every week, and because I'm lazy, I thought it might be useful if we could think of 10 inherent flaws within the evidence-based industry, if you will, and I'll use that as a template for a column next week. It certainly saves me having to think about it. So what I'm looking for is I have some certain ideas about the things I think are very important, but I'm very interested to know what your views might be, whether you think there is any problems with evidence-based medicine. So I've gone very low tech. Can we see this? Oh God, is that me? Am I bald? Anyway, okay, so top 10. There's an interesting concept which I've thought about for quite a long time, and that is the issue of commissioning bias. I think I came up with this. I don't know. I'm sure I read it somewhere. But are people familiar with that concept? No? The inherent problem with evidence-based medicine is that to do an evidence-based review, you need to have clinical evidence. So who is it that fundamentally controls the evidence base? Predominantly pharmaceutical companies, because they're the people who have the resources and the motivation to conduct clinical studies. So when we think about evidence-based medicine, one of the inherent flaws is that it's largely therapeutically led. So there's an inherent commissioning bias in the whole of the evidence-based agenda. Can you dig that? Or does yeah, you could nod, show hands. Okay, okay, fair enough. But this is something that we've never really tackled. I mean, for example, there's a lot of discussion about modifying HbA1c, high blood pressure in people with diabetes. But if you took the opportunity costs of the money we spent on anti-diabetic drugs to try and improve people's lifestyle, incentivize them in some way to change, how would that compare to the outcomes of modification of risk factors? That type of thing? Make sense? Okay. Has anybody got any other thoughts about flaws with the evidence-based medicine they want to shout out? Mics?
Where's the microphones? Yeah. Bravo. So how about hands up for any, is that what you like, Des?
Yeah, this is my idea. It's going to be a pretty short column, I need some help here.
So there's a hand. Catherine's got a hand up. There's a GP here with a hand up.
You can shout out.
Actually, I'm afraid the acoustic isn't very good. So if you could, there's Catherine first and then the lady here.
Catherine Meads. I used to work for NICE Technology Appraisals, and it used to really bother me that we would be investigating in minute detail the intricacies of one drug versus another. And I would like to find out what other treatments would have done to help people much more than the drug treatments. So, for instance, in depression, what we'd be looking at one drug treatment versus another drug treatment, whereas I would like to have seen what counselling would have done differently to drug treatment. But NICE never appraised that, because the money is in the drugs.
And that's partly because, again, the evidence base was dominated by therapeutics. Yeah. And NICE obviously, understandably perhaps, have quite close links with the pharma industry, certainly did in the past. And so they were very effective at getting antidepressants at the core of what we do for depression. So I think
but it's not just drugs, though. A lot of money's been spent on diagnostics.
Yeah.
NICE are just starting to look at diagnostics at the moment, but it seems to be a huge amount of money is being used on diagnostics, but they're never really evaluated.
I think that's a very fair point, okay. Because we tend to think of evidence as being about treatments, but diagnostics, clearly, there's an inherent problem with diagnostics. For example, if you elect to do an MRI scan on people, you may well find that a small number of them may have evidence of demyelination without any neurological defect. But do they have MS? And that leads to lots of diagnostic uncertainty. Is that the type of thing you were thinking about?
Yeah. And also, like in Birmingham, they've just built a huge new hospital, but I don't know of any evidence base to show that the health of the local population will improve with a huge, big new hospital compared with the existing hospital provision. Yet we've spent huge amounts of money on that. It's a private finance initiative thing. But if you talk to service delivery people about provision of a new hospital, they'll only look at the sort of financial aspects, but not the cost-effectiveness aspects and the health delivery aspects.
Okay.
Well, I think that's a very fair point.
And the GP, sorry, I've forgotten your name, but I know you're a GP.
I'm a GP. Even if I read it in the original data, I can never ever remember whether the evidence applies to the person in front of me. And even if they're the right age and sex and all the rest of it, there could be other demographic problems or comorbidities.
Yeah.
So I'm always thinking, that's what the evidence is supposed to say, or that's the guideline, that's the headline. But is that relevant?
We've touched upon a very important, another point that I was going to raise, which is study populations. Okay, I come from Glasgow. I'm not a Glaswegian, my wife is. What is Glasgow famous for? What, drinking, yeah, anything else? So what's smoking, fighting?
Fried food.
Fried food, yeah, dying early, okay. And so if you, for example, what's the life expectancy difference between, say, the southeast of England and the centre of Glasgow? It's about 10 years, okay? Even if you look at the, even if you modify for all the various risk factors like cholesterol, smoking, that type of thing. So there's an inherent... Who lives longer? Oh, the people in the southeast of England, not in Glasgow. But Glasgow has the infamy of being a city that has the highest rate of ischemic heart disease in almost the sort of Western world. And so if you were going to do a study, so whereabouts do you work, sorry? South London, right? So if you're going to do a study, where would you do the study? Into, say, cholesterol lowering? You're doing Glasgow, okay? So study populations, you look at study populations, they're always chosen for one reason. They are high-risk populations, okay? So, for example, if you look at osteoporosis, have any of you looked at some of the primary fascia data on osteoporosis and primary prevention? Do you know what their T-scores were? Do you know when they looked at treating their osteoporosis, where they were within the standard deviations? There were 3 standard deviations from the mean. Okay, so the study populations are always chosen because they know that any intervention was likely to have an effect. The problem is that if you then, so you have a landmark study like the WASCUP study, which actually didn't show any benefit on all-cause mortality even after 5 years worth of treatment, but showed a 25%, 30% reduction in ischemic heart disease and vascular disease events. This data is then extrapolated into other groups. Okay, so you get this sort of disease creep. Okay, and so study populations are fundamental, and they're chosen for very specific reasons. And you cannot extend that data from the study populations into broader populations. The other thing is, this is a GP thing. Who's most health neurotic? Okay, how many of you go running here? Okay. How many of you smoke? How many of you drink a bottle of vodka a day? Okay. You are a bunch of health neurotics, aren't you? Okay. Middle-class people tend to be very health obsessed. So if you bring out a treatment for, say, something like cholesterol, who is the person that takes on these health messages? Okay. The people least at risk. Okay, so you find the inverse care effect. Not only is the study population, say, in the southeast of England very different from those in Glasgow, the people who want to take treatment are generally at much lower risk anyway. Does that make sense? So their absolute benefit from intervention is infinitesimal, if at all. Okay. Any other thoughts? Any other contributions?
And there's one here. So, yeah.
Yeah, you already mentioned it with commissioning bias, but I would explain it a little bit further. I mean, patentability bias. If a treatment is commercially exploitable through patent rights, it's much more likely to attract research funding, therefore produces much higher quality evidence, and is therefore hugely advantaged in comparison to other areas.
So these groups are stripped down intentionally by the pharma companies to show an effect. Is that
patentability bias, so whether it can be patented or not.
The medication.
So whether the treatment can be patented.
Yeah, okay, that's a very good. I hadn't thought of that, but
you might appear in the column next week.
Yeah, well, I'll steal that one.
and Rachel.
I'm Rachel Armitage. I'm the director of the BMJ Evidence Centre, and there are two things that I worry about. One is that up-to-date evidence seems to be a bit of a contradiction to me, because by the time you've carried out the systematic review, the evidence has moved on, so that's one issue. The second issue that I really worry about is the real evidence base, the missing data or the unpublished evidence that we've talked about at this conference before, and that's why I find most worrying.
Yeah, I think that's a point that was in the BMJ a couple of weeks ago. I think you're bringing out a special edition, are you not, next year, looking at missing trial data. And I think that's very, very important, because trial registration is relatively new. Trial registration isn't appropriately policed. There's lots of issues around incomplete, suppressed and data, and there's so many examples. There's almost, I'm sure you know these things, that there's obviously Avandia, reboxetine, Seroxat, Vioxx, all of which have evidence that the data in some way has been manipulated by that company. And the problem as well is that trial data is largely, it is owned by the people who conduct the trial work. So pharma companies actually own that data, and it's very difficult to get access to the kind of raw data that people need, or people who might want to refute the assertions within the trial.
And the other point was, the up-to-date bit, Des.
Sorry?
Up-to-date. How?
Up-to-date. Okay. Well, I'll tell you. Up-to-date, right? Up-to-date. You can tell I am a doctor. I can't even read my handwriting. Okay. When you say up-to-date data, should we have a show of hands, do you believe that giving people statins, reduces the chances of developing ischemic heart disease? That's a very simple question. Who believes that? Okay. If you look at the incidence of ischemic heart disease, or vascular disease generally, it's been in decline since the 1950s, and that trajectory of decline has been fairly static. And some of it may be related to better medical care, but generally speaking, it couldn't be, because so much of the decline actually occurred before our medical interventions, and it would be about 1990 that people were getting thrombolysis and aspirin, and I suppose 1995, and probably even later than that, for statin use. Okay, so the trajectory of decline has been relatively unaffected. Now, my point is that if the numbers needed to treat to prevent a vascular outcome with a statin in the original research studies, which would be the populations from 1990, that say the numbers needed to treat, for argument's sake, were 50. If the background incidence has changed, so the background incidence of ischemic heart disease has changed, then the relative effect from treating with a statin means that those numbers are wrong. So the data is out of date. So your NNTs today, because the incidence has declined by 50%, may be 100. So what happens is that sometimes if the epidemiology of a condition is changing, and it changes all the time, things like rheumatic fever, TB, that they change not just because of medical intervention, the natural epidemiology had changed, that has an impact upon the evidence base, and that's never factored into the discussions when we talk about evidence-based medicine. Is that a fair point? Yeah. Let me throw that off. Okay. Any other things that make you mad about evidence-based medicine? Okay, should we get angry about this? Well, as angry as doctors do, but slightly angry, slightly irritated.
Jan Ostera, GP in Brighton. I think what worries me is sometimes the absolutism of evidence, and also as a result of that, if there is absence of evidence, there could ensue paralysis of decision making or rejection. And I think for me it's a question how much we go for evidence, how much we succumb to the promise of it, or whether we just use it as a part, or a very important part of clinical and management and commissioning.
And how many times have we sort of been in clinical situations where people say, well, where's the evidence? Or the evidence says this, and it's applied in an absolute way without a reflection on the limitations of that evidence. And as you say, it doesn't afford the reflection on the person's personal circumstances, the situation or where you might be working. So there is an inherent problem with the absolute nature of clinical evidence.
And in that absolutism, of course, again arises what we have discussed for the last half an hour, and that is that the data, in my opinion, and a lot of my colleagues, can be manipulated and can be interpreted in all sorts of ways, and it makes it very, very difficult to understand.
Oddly enough, evidence-based medicine, rather than making our lives easier, as we thought it would be, I think has actually made it a downside more difficult sometimes.
And disempowering if there's a lack of evidence. One might, what you're saying is, well, what can I do? And so you forget that you've got clinical skills.
Yeah.
There's one there.
A point about screening programs and the overdiagnosis bias of, you had the vigorous debate in the BMJ on breast cancer screening, and it applies to prostate and lots of other cancers as well, and probably other screening programs as well. So we find all this disease which isn't actually helping people.
Well, I think overdiagnosis bias is again something that isn't recognised. What isn't debated enough, certainly not in the broader media. Screening is viewed as being a good thing. There's that sort of inherent kind of unilateral thinking that somehow we pick up something early, that there's going to be a better outcome. And I think there's overdiagnosis across all screening programs. But obviously the recent stuff in the BMJ, well, it's been an ongoing debate, I think has helped to actually bring that into some sort of focus.
Great. I've got one at the back there, a lady at the back, and I've got one, two, so just the lady at the back there. If you raise your, that's fine. And then there's one over here.
My concerns with evidence-based medicine and evidence in general is that we're taking information from clinical trials, which really it's a created situation. In practice, you don't have patients who meet internal and external inclusion external criteria, and we're trying to bring that into patient care where you've got individuals that aren't necessarily meeting hard endpoints that you would find in clinical trials, but they're people. It has to be holistic, and how do you, in a fair way, take that evidence through to patient care where you have all those other considerations.
And you have that conflict between you and the patient, don't you, where you, maybe through the QOF or for reasons that you think it's the best evidence, that you feel they should be on treatment, and they're like, well, I actually don't want to be on treatment. And that leads to a conflict within the doctor-patient relationship. And because the easy thing in clinical practice, the easy thing in life sometimes is intervene. It's more difficult to not to intervene. And we're often caught by that sense that if we don't act, that somehow we're going to be responsible.
And we've got one here and then one 3 rows behind here.
How about our failure to confront or address our ethical mandate to make clinical research an expectation of any patient entering the healthcare system?
Okay, so really this notion about there's the science of medicine, but much more importantly is the ethical context in which that science is applied, and there's very little sort of research, very little debate about that. Is that the type of?
Well, I think we all hate the notion that there's something suspicious about clinical research that isn't present in the other kind of clinical care that goes on without a research basis. There's something to be feared about it. We need to address that, and we need to address our research.
And I think also research is slightly esoteric, it's slightly distant, isn't it? Whereas when we're doing clinical interface, we've got lots of other cues and knowledge of the patient that inform our choices. Whereas the evidence sometimes is sort of parachuted in, and it's difficult to know where that fits in.
But there's a notion that it's self-satisfying, it's something for us and not for the patient, and that it's a threat to the patient. And that is a disseminated notion, and the research ethics boards to some degree buy into it.
Can I just clarify? Sorry, the evidence-based medicine is a threat to the patient, is what you're saying. They feel it as a threat.
Clinical research is a threat to the patient. Now, have a patient take a decision that is randomized is considered worse than having a patient take a decision that is arbitrarily chosen by somebody who's not informed.
Oh, and behind you, yes, sir.
A couple of issues about risk. One is number needed to treat. I think if we clearly told our patients what the number needed to treat is for, say, moderate hypertension, they wouldn't take the tablets. And it's quite possible that people confuse relative risk with absolute risk.
Well, we all do that, don't we? I mean, how many doctors do we know who don't actually understand the concept of relative risk versus absolute risk? Well,
I'm sure the patient thinks that if 27% people have a problem and you reduce it by 25%, that's 2% left.
Yeah. Well, I'll tell you an interesting concept as well, which is this notion of there's a screening paradox, isn't it, in the sense that the vast proportion of people screened never benefit from screening. In actual fact, it's worse than that. They may suffer overdiagnosis. But even within the context of treatment, there's a treatment paradox. Which is something I feel very strongly about. That even with the best NNTs, I mean, say the best NNTs were, I don't know, 20. I mean, but that would be over, because you're not allowed to annualize NNT, so that might be 20 over a 5-year period. So that might be, if you analyze in cheap, that might be 80. So that's, 80 people who in effect don't benefit from, 79 people don't benefit from treatment at all, despite 4 years worth of treatment. So you're asking people, when it comes to taking medication to modify their risk, to take medication for absolutely no benefit to them. What do you think? It's an interesting idea.
Dan Mayer from Albany, New York. The general population doesn't understand science, and they don't understand risk, and they don't really understand any of this evidence stuff. And frankly, many physicians don't either.
Yeah, well, I think it's very true, and I think the thing is that we find it very difficult because we're all very clever people, very erudite, and we've been schooled very heavily. So it's quite difficult for us to actually admit that this is quite an abstract concept, and we don't understand it. I know lots of very bright doctors who, if I was honest, they don't understand. They find it very difficult to look at clinical papers, and they find it very difficult to disseminate risk to the patients. So maybe actually, as a community, we're a bit better at acknowledging that might go some way to
treating conditions like chronic pain with opiates. The evidence and the effect is quite controversial.
Yeah.
And there is quite a few information about risks of opiate use in chronic pain. And what are your views about it?
Well, it's a very good point, actually, and I've managed to upset the pain community on that topic on a number of occasions, I'm afraid. And I think that probably raises a point that is another very important issue. Probably a fundamental issue. How do you define pain? I'm sorry, how do we define pain?
Pain is what the patient says.
Pain is whatever the patient says it is. So it is subjective. So can there be a big variation reported incidence of pain? Hugely variant? Is there a cultural development? Is there an age dependent? Is there a gender element to it? Okay, so that when we think about definitions, even you take the best research, and then if you unpick it and go to the root of it, and you say, well, you look at their definitions, you think, well, hold on a minute, their definition is bullshit. Okay, I mean, for want of a better word, that to suggest that pain is whatever the patient says it is, in my opinion, is fundamentally wrong. Okay, not because you shouldn't treat people, believe people, and relieve suffering. I mean, of course that's what we should do. But if you don't, if you don't have an element of skepticism in self-reported symptoms, then it leads to all manner of problems. And if you look at the States, for example, particularly with opioids, there are more people dying in the States, in certain of the independent states across the US, from unintentional overdoses from prescription drugs than dying on their roads. I think I have a figure here somewhere. I think they've had 39,000 people die last year from unintended overdoses from opioids. But if you suggest this to the evidence community, if you suggest this to the pain community, they go completely crazy. Okay, and it's like, well, and if you say to me they've got the definition wrong, then again they go back to that. I mean, there's lots of other issues around definitions as well. Okay, can you think of other examples?
I told the patient that 50%. Sorry, just bear with us. Here it comes.
I tried to tell the patient that 50% of people were below average, and he really struggled with that. He said, "No, that can't possibly be true."
Yeah, well, that's how about if you look at the numbers? Okay, if you want to look at numbers, I'm not a great conspiracy theorist, but if I was running a business, which I'm not, that I would run my business like a pharma company. Okay, I would run my business like a pharma company because it makes business sense. So if you're a pharma company and you want to make money, what conditions do you choose? There are two types of conditions. They're prevalent, so you want them to have a high prevalence. So you want lots of people on your medication, and you want them to be chronic. Yeah? So if you look at the current sort of debate within medicine and debate within sort of broader society, you'll find that most of it's focused upon chronic disease. Is that right? Then, so you define your chronic disease, and then you get disease creep. Okay? So, for example, CKD. I hope any nephrologists here? Oh God, okay. If you say CKD, which is chronic kidney disease, what percentage of the population have got it? 10%. Okay. If you take pain, what's the reported incidence of chronic pain in the UK? About 20%. What's the reported incidence of depression? About 30%, supposed to be in GP surgeries. Okay, ADHD in the US, 10%, maybe more than that. PCOS, polycystic ovary disease, 25%, 30%. Okay, osteoporosis and osteopenia over the age of 50, 50%. So you can see that the definition of our diseases, from an evidence point of view, has actually enveloped large proportions of the healthy population. Okay, and it's taken away people's sense of well-being. But without well-being, you have no health. Is that a fair comment? I mean, how often do we sit in our surgeries or we sit with patients and you know there's nothing wrong with them, but they are chronically anxious about their health? Is that a byproduct of their own personality? To an extent it might be, but it's also a byproduct of what we have done to them as patients. Is that a fair comment? So when we think about the evidence base, we have to look to our notions of sort of definition. Is that we need to rethink or challenge these notions, but it's very difficult because we live in a very fragmented medical world. Whereas if you're not an expert, you're not in a position to make a comment in an expert field. Is that a fair comment, do you think? I upset a lot of experts because I make sweeping statements about certain conditions that they find offensive. I do it intentionally, of course, but and I feel, that having reviewed the evidence, that I'm in a position to make those comments. But there isn't the fractionation of healthcare, and particularly the medical profession, and loss of generalism has allowed this to happen. Is that conspiracy theory again? Kind of. Any other comments from the floor?
One here.
Rachel Armitage, BMJ Evidence Centre. I think one of the problems with the evidence base is it assumes that you just have one thing wrong with you. So comorbidities, multiple morbidities are often ignored, and I think that's a big issue.
Well, that's a big issue. I don't know what we're on, comorbidities. It's a big issue from a patient's point of view, isn't it? Because if you've got comorbidities, say you've got hypertension, high cholesterol, osteoporosis, I mean, how often are you at the doctor? You're there all the time. How many medicines are you on? I mean, evidence-based medicine would suggest that we must treat or intervene and leads to polypharmacy. So comorbidity causes polypharmacy. And how many people die from polypharmacy a year? This is the BMJ. Any thoughts? Well, as a direct adverse consequence of the medication or the polypharmacy? Lots, I think. Apparently, I read in the BMJ a few years ago that as many, sorry, it's another car accident analogy, but as many people die from adverse drug reactions as die from on our roads in the UK. But I'm sure, and again, if you think about it as practicing clinicians, how often have we seen this? How often have we seen it? And again, that's a direct consequence of evidence-based medicine. It's a direct consequence of not thinking about comorbidity. All right, how are we doing?
Yep, there's two at the back there. I'm on there. Sorry, I didn't come to you. Two at the back.
So was there another point?
Yeah,
sorry.
Thanks, Des. Alex Clark, University of Alberta. Two things. Most reports of trials and meta-analyses don't describe interventions well enough.
Yep.
And secondly, underpinning a lot of what's being identified is a philosophically impoverished view of causation, whereby if you do A or with patient B, C will happen. Whereas in reality, causation is generative. Complexity theory tells us this. You need lots of things coming together in the right combination to generate the appropriate outcome. Context, values, the interaction between the physician and the patient. So we need to get to the heart of what we understand causation to be before we can improve evidence-based care.
This is the whole point about evidence-based medicine. It's become reductionist, hasn't it? In a sense, it's reduced what we do to somehow being a flow diagram. That any way that you can treat somebody, no disrespect to the guys who are doing from NICE with the flow diagrams, but that is in itself quite reductionist. Is that a fair comment? Please forgive my spelling. Any other comments?
Yeah, it's Jonathan Bamber from the Health Foundation. What I find interesting that most of the discussion from the last 2 days has been on better evidence, which is good, but not too much focus on the dissemination, communication, and transfer of good knowledge and how people pick it up. There was reference you made a few minutes ago to people not understanding what evidence-based medicine is. We've got to ask ourselves whose fault that is and how much time and energy we need to be spending on translation, communication, etc., etc. Most funders...
I suppose the point is, so here's an analogy, if you're not able to drive a car, okay, if you haven't been taught how to drive a car, should you be driving a car? Do you see? Yeah, so I mean, you're right. I mean, if we don't focus upon evidence-based medicine and teaching evidence-based medicine, but that isn't in a kind of as I said, in a flow diagram way. It's about making people understand the limitations, because the only way that you can apply evidence-based medicine is if you have a good grasp of the limitations of the evidence-based. So I think that's probably a very fair point, that there's an enormous opportunity from an educational point of view.
Mine was probably related to the reductionist thing, the treatment of surrogate markers as if they're diseases. Sorry.
Yeah, sorry. You see me scanning, I can't...
Yeah, so treating a vitamin D level or treating a glucose level, not treating the disease, not treating the person.
Fantastic, actually. This is, surrogate endpoints drive me up the bloody pole. So can we think of examples of surrogate endpoints? You mentioned HbA1c. Any other thoughts? Cholesterol, any other ones? I suppose so, yeah. Sorry? Blood pressure, yeah. Sorry?
Length of stay.
Yeah, absolutely, yeah. So surrogate endpoints are used all the time. And surrogate endpoints are used to manipulate. I mean, for example, rosiglitazone had no hard evidence base for its effect, but it's got its license on the basis of lowering HbA1c, which is a surrogate endpoint in diabetes. Cholesterol, likewise. And the problem is that, and it's not so much that there's composite endpoints as well. And then there's subgroup analysis. You're familiar with all these things, aren't you? I'm sure. You know, these are sort of ways of sort of manipulate the data after it's been through the kind of trial. I think. Surrogate endpoints. Yeah, again, an interesting thing from a surrogate endpoint of view is the study into the use of biphosphonates. Have any of you read the data on that? Okay, if you look at the data on fractures, okay, which is significant when it comes to vertebral fractures, they're actually not clinical fractures. They are fractures found on imaging. So the whole premise of osteoporosis is mainly based upon surrogate endpoints. The use of biphosphonates, there is not one trial suggesting that they have an impact upon mortality. And that when you think about it from a biphosphonate point of view, the idea is that by preventing fracture, you prevent death. That has not been proven, but it's very, very widely used, and you get disease creep where you get everybody. I mean, so many of the women that we have with osteoporosis are in their 60s, perhaps even in their 50s, and there's no trial data to suggest that it makes an impact upon them. What else? Okay. How about study length? Any thoughts? Always too short. Why? Yeah. Well, you know, there's lots of reasons why, but I mean, fundamentally, it's an opportunity. If you make it short, then you don't have time for the non-intervention group or the intervention group to catch up from a mortality point of view. Studies are often stopped early, aren't they? And that in itself distorts the outcome data. If you look at statins, for example, just the reason I focus upon, say, risk modification is this is a big chronic disease. This is where the money is. If you look at statins, are statins safe? Who's prescribed statins? Okay. So are statins safe? Well, you'd think that. I'd hope they were safe. Okay. But are statins safe? How do we know they're safe? Because they've said they've been used in 68 trillion billion patient years. Yeah? Okay, but are they safe over 3 decades? Are they safe over 4 decades? Do we know this? We don't. So there's lots of issues around post-marketing and follow-up of medications that have never been addressed, and around the safety. We put lots of effort into doing the trials, but we put no effort whatsoever, well, very little effort into the post-marketing follow-up and the safety profiling of medicines afterwards. Is that a fair comment? Any more thoughts on the floor?
What about studies of lower quality, so observational studies? What do we do with those?
Of what, sorry?
Observational studies, so not randomized control trials. And what do we do with them? How do we use them? Is it possible to use them?
I think, you know, you have to use what evidence you have. I mean, you know, sometimes I actually quite like observational studies, because observational studies are, you know, strong from an epidemiological point of view. The epidemiology of conditions is very poorly studied. But that poor epidemiology is then, you know, hoisted up and taken away by the pharmaceutical industry. For example, what percentage of women who get chlamydia go on to develop PID? Okay. Have any of you treated people with chlamydia? Show of hands? Okay, so I've got a rip under that one. So what do you tell patients? Because there's a national screening program for chlamydia, isn't there? So there's a national screening program for chlamydia to reduce the incidence of infertility, which would be the prime endpoint of screening. Who's done chlamydia screening? Okay, we get paid to do it. Okay, that's another fantastic thing. Incentivize people to bring about evidence, and we do it, even though you might think it's wrong. Okay. But the initial the initial epidemiological data for chlamydia was based upon an assumption that 40% of people with chlamydia would go on to develop PID. That was based upon a paper in 1978. And that was the premise of, much of the premise of the screening program. But if you then, because this was a hospital population, if you then go back and look at the broader community, you realize that couldn't possibly be the case. It couldn't conceivably be the case because 10% of people under the age of 20 have got chlamydia, okay? Therefore, 4% of the population at any given time have got PID. So, and that didn't reflect the truth of the situation. Plus, what would happen if you didn't treat chlamydia? Would it clear itself? Well, if the point prevalence if the point prevalence was 10% when you were 17, and it was 1% when you were 25, chlamydia must clear itself. And if those are point prevalence, what's your lifetime risk of being exposed to chlamydia? Who knows? But it could be up to 30, 40% by sort of guesstimate, by my guesstimate. So, when we talk about, we should perhaps put more weight on observational studies. We certainly need to put more weight on the epidemiology. We don't need more pharma studies. We don't need more studies into medications. We need some basic epidemiological study about the prevalence of disease, its natural history, and how it resolves. But that's not a focus for the industry, and it hasn't really been a focus for the NHS. Is that a fair comment? I'll stop ranting. Anybody else?
Another problem with evidence-based medicine is statistics. Working out, I'm a journal editor, so working out whether the authors of the studies have done the right statistical analyses in the first place, whether the peer review, trying to find statistical experts as peer reviewers is very difficult, and then as clinicians reading those papers and trying to work out what the answers mean, what the stats means if you're not trained to a very high degree in stats is very difficult.
Well, and the other thing is I don't think stats, even if you are trained to a high degree, is very easy. Okay, because stats really are a conceptual thing, and it's very difficult. Some people struggle with mathematical conception, and that's just, some people are better at football, some people are better cooks. It's just the way things are, and it's very difficult to teach that. That's been my experience. But yeah, I mean, the application of statistics, particularly in the media, is a big issue because we were talking before about relative risk versus absolute risk. If you have a relative risk reduction of 30%, people are up in arms, they're clapping, saying whoopie-doo, we've cured whatever we might have cured. Yeah, any other points?
My difficulty with it is a sort of epistemological one. A lot of evidence-based healthcare practitioners, doctors, scientists come from a positivist or realist perspective, whereas a lot of the public come from a relativist perspective. And the whole idea of something like evidence-based medicine or trials showing a result seems completely anathema to them. So from their perspective, we're completely missing the mark. And they think we're bonkers to try and predict what's going to happen from trials and use this information to dictate what sort of treatment to give them. And because we're all coming from a scientific background, we're not really getting to grips with the way they're thinking about us, because we can't see it from the outside.
Yeah, and it goes back to that notion that we're taking evidence, which we view as being relatively absolute, and applying it to a person in front of us. And there's that conflict between the doctor as clinician and the patient who's actually taking the medication.
Hello, I'm Matt Roy from Glasgow, and what I found...
Sorry.
Here in the middle. What I found is one topic which comes again and again. You can, and I think it's just the way you look from different sides, you give it different names. So you could call it waste, in a sense that research is done which is needed. You could call it commissioning bias, in a sense that whoever that just thinks that are actually worth for somebody to make money out of it will be done. But you could also say that it's a luck of coordination, that there's nobody actually in the community, or is a lack of communication between the people who do the research to say what is needed and drive that forward.
I mean, I think the whole kind of problem with medicine is it's fractionated, it's quite broken, there's very little oversight. You know, often we get guidelines passed down from various agencies, and we're expected to implement them on the ground. It's like, well, this is, you know, we feel like, well, these are nuts, but you've got to do them. You know, so as you say, there's poor communication oversight between the people who do the research and the people implementing it, and also the patients.
Yeah, it's a.
Sorry.
Most trials are conducted under very artificial conditions, or efficacy trials. In Scandinavia, they looked, for instance, for asthma trials. What would be the percentage of asthma patients in a normal GP or pulmonologist practice who would qualify for an asthma trial or COPD trial, and it was less than 2%. And these data are then, they proved an effectiveness or efficacy. And this is then extrapolated to the highly complex population which we see in the practice, which has 2, 3, 4 diseases, several different pharmacies which cross-react, and we don't know at all if we actually do harm in these cases.
Well, I think that's the point you say at the end, that, you know, we're nearly finished. I mean, I think the most important point about evidence-based medicine is it has capacity to do good, but it also has capacity to do harm. And it's about time we actually acknowledged that and reflected upon it and thought about the harms it might do. Because one of the other aspects is that once you start treatment, it's very difficult to stop treatment. You know, once you start somebody on an antihypertensive or cholesterol-lowering drug, even if the evidence base changes, even if the circumstances change, we never stop the medication. Well, we try to, but do you know, that's it. And that's an issue. We need to think about how we start medicine, but we also need to think how we stop medicine. The other point I had down here is cost-benefit analysis is all rubbish. Is that, people agree with that? You must do. Cost-benefit, it's always wrong. I've never known cost-benefit actually be right. So you think? They come up with all these numbers and you think, oh, that's going to work. I remember when they brought out atypical antipsychotics. They said actually it was going to work out cheaper because fewer people were going to be hospitalised. But in actual fact, it may, you know, actually increase the overall cost, and, you know, obviously care in the community changed hospitalisation. But, you know, there were lots of problems with cost-benefit analysis, partly because they also are done by pharma companies. But anyway.
No, I was just going to say, and we've got a kind of 4 minutes or so. I mean, would you like, there's been a lot of the problems, and this is going to be a marvellous column, I can see it already. In the last 5 minutes, your closing thoughts, and perhaps some solutions, or is that too much to ask?
I mean, you know, the thing is that, you know, sometimes if you sort of rail against a machine, you're very much, you know, in the darkness. You're seen as being sort of crazy. I mean, I think the issue is that there are real problems with evidence-based medicine. There are real issues that we need to address. Evidence-based medicine is a fantastic move, advance from what I experienced first when I went into clinical practice. It's a very important part of our work, but it needs to be redefined, rethought, and we need to go back to some of the basics of looking at the epidemiological data that needs to be resolved. So that would be.
Well, I think on that note, and allowing people to have a brief break before the next session, Des Spence, many thanks indeed for a really inspiring session.